Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on these surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I am looking forward to our discussion on the recently published article in SurgiColl titled Opioid Administration Patterns and Trends Following Total Joint Arthroplasty, a Multi-Center Analysis. In addition to discussing this article, we will do a deeper dive on the current pain management strategies around total joint arthroplasty surgery. So for this episode, I am excited to be joined by Dr. Ahmed Siddiqi and Dr. Antonia Chen. A little background on both of them. Dr. Siddiqi is the senior author of our paper today. He is an assistant professor of orthopedic surgery at the Hackensack Meridian Health School of Medicine in New Jersey, where he specializes in total joint robotic surgery. Dr. Chen is our guest expert. She is a highly experienced total joint surgeon and a key opinion leader in the field, who is now the chairperson and professor of orthopedic surgery at the UT Southwestern Medical Center. She was previously on faculty at the Rothman Orthopaedic Institute, where we first crossed paths, and Harvard Medical School. So very excited to have both of you guys here today. I appreciate it very, very much having you guys join us. So first off, let's start with some easy stuff so people get to know you. I have a couple questions for you guys, easy stuff. First for Ahmed. As the senior author of this paper, just broadly, what inspired you to get involved in clinical research? I know you're well published in the field and have been an investigator for quite some time. What inspired you to get involved in the research process?
Yeah, so research for me was always inspiring. I read a lot of papers from, Jay Parvizi, Antonia Chen in residency, and I was lucky enough to cross paths with Antonia in residency as a junior resident, and she kind of paved the way for me. She was, our collaboration was my first JBJS paper, and then came another JBJS paper, and then came another JBJS paper, and this feeling like we were contributing to the literature and kind of advancing, what we were trying to figure out was really, really inspiring. And those initial years in residency, I've never looked back. I mean, I'm always looking to see what's being presented in the current literature and how we can do it better, see what some of the limitations are, see if we can, solve some of those questions. I think review papers are pretty critical in terms of surgical techniques, or just review papers in general for the Yellow Journal. So I got a lot of experience with Antonia on that, and I've kind of learned a lot from her as well. So.
Well, I can tell you that my own experience, Antonia has been a very accomplished surgeon, but probably I think one of the best hats that she wears, which a lot of us take pride in, is being a mentor. And I know she's been a strong mentor for many of us and many joint surgeons like yourself. Antonia, let me ask you kind of a broader question. What drew you to your specialty of total joint arthroplasty surgery?
So clearly you're surrounded by two joint surgeons. So obviously it's the best subspecialty there is out there known to man.
I'm definitely outnumbered for sure, but go on.
You are. So I'm sorry, but not sorry about that. Really, actually, I didn't think I was going to do orthopedics. I thought I was actually going to go be a pediatrician. During my first year of medical school, a hand surgeon came us and taught us the hand. And so I became interested in ortho through the hand, ironically, since no offense, I don't like the hand anymore. And you always have to do a research project between your first and second year of medical school. And I ended up doing a research project with Dr. Alfred Tria. And I went to surgery with him. I got to see his patients before and after surgery. And I basically saw patients go from not walking to walking. And that's what I want to do for the rest of my life. So it was mostly knee replacements at the time, but obviously we know our hip replacement, knee replacement patients do quite well. So that was really the impetus of choosing arthroplasty.
That's a great story. I think there's a lot of folks who can relate to that. It's often about finding someone that kind of inspires you along your kind of educational journey and connecting with that. Another question for you guys, one kind of final kind of soft question to get started, but one I think it's kind of fun to kind of get going. What was your most favorite or most hated medical TV show or movie? So is there a show or a movie that you guys loved? Because there's so much of it, and it's funny how people have really strong opinions about it. I'm curious if there's any that really jumps out. Emma, do you want to go first? Any ideas? Or
Yeah, So I
Okay.
think all those medical shows and movies, they're very comical in terms of the medical side of things. I think they're really entertaining because of the pure drama and some of those, entertainments in terms of the romances between the actors and stuff. But from a pure medical and accuracy standpoint, they're pretty comical. I remember in residency, we used to watch The Resident. Me and my wife used to watch it, and it was pretty, gruesome. The patient comes to the ER, they're going from the ER right to the OR, and no one's wearing a mask. They're just scrubbing in, just dry scrubbing in. And it was my wife used to be like, "Oh, that's how it goes in the OR." I'm like, "Not really. We don't really use our bare hands without scrubbing and touching the heart and things like that." But yeah, it's always interesting to see that. So I prefer seeing more law shows because I know a little bit less about that. So I pretend that that's more real life. But I think all those medical shows, I think it's purely for the drama that we watch them.
I'm sure the legal shows are probably equally guilty of all that. But
Exactly.
Antonio, what about you? What would you
I
think of
grew
that?
up watching ER, and I
Mhm.
still like that show just because it was an original. I call it, like an OG medical show. That's what I didn't want to necessarily be an ER, and I wouldn't even want to be a doctor really necessarily, but it was just cool to see those scenes and, fantastical things that they would make up of coming with a pole stuck in them and, being able to extract patients and stuff like that. Grey's Anatomy started when I was an intern, so my non-medical friend from college called me up and go, "You need to watch this show because it's about interns." So I watch it, and of course, he calls me a few weeks later, and he goes like, "So have you met your McDreamy?" And I'm like, "No, absolutely not. My attendings did not look like that." So that was too drama, too much, all that stuff that you're talking about. I mean, that I was like, not so excited about. I did watch a few seasons of it. I'm going to be honest, but that was on my nay list.
Well, I think that show's still going. It's like in its
I'm
20th
shocked.
year. Because that show started when I was a fellow, so that was like 18 years ago for me. So like that was so. But I
Impressive.
definitely would agree with you with ER. That was a great one as well. So, all right, well let's get down to some business here. So let's jump to the article. So, Dr. Siddiqui, as our author, senior author of this paper, your paper focused on opiate prescribing after total joint replacement surgery at three different academic centers. My kickoff question for you is: can you tell me a little bit about the study design, and then ultimately, in terms of the results, what surprised you or didn't surprise you about the findings?
Yeah, so this was a retrospective analysis utilizing a data set obtained from Avalon. And Avalon is basically a value based data analytics company that provides healthcare related data for payers, providers, and other healthcare companies. And we basically utilized it for three geographically diverse institutions. One was in New York, the other one was Iowa, the other one was in Louisiana. So it basically represented the Northeast, the Midwest, and the Southern region of the United States. And what we were really looking for, it was, basically the administration of opioids within the healthcare setting immediately following the respective surgeries, which was primary knee replacements and hip replacements. And we looked at the morphine milligram equivalents representing basically the potency of the opioid dose relative to morphine. And I think the entire results was kind of surprising because during those episodes, those surgical episodes, uh, over the past 3 years from when we looked at, it actually went up for inpatient and outpatient surgery. Overall, inpatient went up a little bit higher, a little bit more than outpatient knee replacements did, and knee replacements were a little bit higher in terms of opioid utilization compared to hip replacements. I think that was a little bit less surprising. I think knee replacements are a little bit more painful to begin with, so that wasn't as critical. But the fact that both inpatient and outpatient went up was a little bit surprising to us. I think one of the biggest limitations of our study was the fact that it really looked at the procedure itself immediately after it within that setting. It didn't necessarily look at 1 week, 2 weeks, 3 weeks, or 90 days afterwards. So I think that's where upcoming and future research will be because there's so much variability involved. And we also didn't look at multimodal pain during those specific patients because it was a retrospective data set study. So I think there's a lot of information that we can take from this and kind of tease out to see if there's any correlations, if there's any trends, and things like that.
So, Dr. Chen, building off those comments, and not necessarily specific to the article, I think Dr. Siddiqui did a nice job kind of laying it out. And I too, by the way, was surprised by the increasing prescribing it. And I think it goes to show you that despite our increasing awareness of the need to be more succinct with our opiate prescribing and utilize multimodal strategies, it may not always be the case, and there's going to be some discrepancies around the country and disparities, I should say, and inconsistencies around the country. But Dr. Chen, building off those comments, any lessons for our practicing surgeons about the current paradigm around opiate prescribing after total joint surgery?
I also found the results to be surprising because I think there's a lot of education over the last, 5 years, really led by you, Asif. I'm really thankful for the initiative you took in, making sure that we try to reduce the amount of opioids we prescribe because opioid prescriptions being high lead to potential addiction and long-term opioid use and things like that. So it's one of those things where I think a lot of times the practice patterns that we do are driven by our patient population or expectation of patient populations. And I remember being a resident and we would give 120 pills, for example, after a total joint replacement. And the reasoning for it is because we don't want the patient to call in or be stuck on a weekend and not be able to get an opioid prescription, things like that. So it's possible potentially in some rural communities, for example, that for them to get access to come back in to, get to a Walgreens, CVS, Walmart, things like that might be harder. So opioid prescriptions might be a little bit higher in that patient population. I'm always curious about not just what's prescribed, but how much is used. That's a big thing too, because I think a lot of our patients, I'd say, in Iowa, and they're the farmers, they actually probably use a lot less opioids, but they want to have them just in case they, encounter problems or things like that. So I think practice patterns is to decrease the number of opioids. I love a bunch of studies that have come out that have given some guidelines onto how much to prescribe after certain procedures. Hand, upper extremity does that, lower extremity as well too, and that's just really helpful to give some saying, maybe you only really need 30 pills to prescribe after a total knee replacement. And if you need more, you come back, you assess the patient and see if you can do other non-opioid options. So using those guidelines to lead what we do is what I think is something that has really helped our practices. It's definitely helped my practice to understand what's a good regimen to use. But I think trying to limit the amount of opioids, understanding different practice patterns in patients makes a difference.
Let's build off that a little bit, and let me ask you both a different question. And what I want to ask you about is multimodal pain management, and uh, central to opiate sparing prescribing patterns and pain management in general is trying to leverage multimodal pain management strategies. And there's my understanding and is that there's frankly a ton of evidence in support of it across the various specialties, including total joint arthroplasty. So Emma, do you want to talk a little about that, about multimodal pain management strategies? What do you know about it? What do you recommend based on your understanding of the evidence?
Yeah, absolutely. So before I get to that, I wanted to touch on some of the awareness also. It's still actually really baffling to me how many patients in New Jersey still like right outside of the heart of New York City. I mean, these are very, up in, well-educated patients. How many local, other physicians, primary care physicians still prescribe narcotics for pain control? So I can't tell you how many times patients come to me and they're already on tramadol or they're on a low dose oxycodone or Percocet. And when you ask them, to try to have that conversation about how the pain is going to be managed afterwards, it's always a little bit challenging still in this day and age when there's so much awareness going on. How many patients still expect to have high doses of narcotics after surgery because that's just what's being prescribed to them even before they come see us. So I think you've led the way of creating a lot of awareness amongst the orthopedic community. I think the next step is to kind of bridge that gap to other, subspecialists and primary care physicians because it takes half the office time when we're talking to patients about no, we're not going to give you tramadol and Percocet in your lead time towards surgery. We have to wait for afterwards, and then it just kind of snowballs. So I wonder if some of that still is being influenced in some of the results, from this study. It can certainly have an effect as well, which kind of leads me into the multimodal. So one of the ways I really tell patients, there's a list of like 8 or 9 medications I prescribe to them routinely after surgery, and a lot of them they feel like they're going to have a heart attack, saying, "Oh my God, I got to take all these medicines on top of my other medicines." But the whole premise is the whole multimodal aspect of it. I tell them they all work synergistically, and the whole idea is to kind of avoid narcotics. So if we can tackle their pain using a lot of different medicines, because there's not one magic pill. I wish there was, but with the Tylenol around the clock, with the anti-inflammatories around the clock with, the stomach, the PBIs to kind of help coat their stomach to prevent any, undue nausea, vomiting afterwards. To have a neuropathic pain medicine such as gabapentin or pregabalin, along with a muscle, spasm medication. I kind of do TXA for an extended period of time after reading some early studies, and we're kind of looking to that as well. And I think that's made a tremendous difference in some of my knee patients as well. So I really take what the current literature has offered in terms of medications, intraoperative and postoperative, along with, focusing on their whole health. I have my patients take protein supplements, vitamins to kind of boost their immune system. And I do think that that has some sort of effect on pain afterwards as well. And ever since I started doing this a couple of years ago, my narcotic utilization has like really, really gone down tremendously.
Antonio, let me come to you with the same question, kind of building off what Ahmed said. And again, with the multimodals, it's about tackling pain from different aspects of the pain experience, the pain pathway, while mitigating or decreasing the reliance of opioids. So rather than making first line, it becomes your backup or your breakthrough agent. But I find, and as you know, we've done a lot of work on this. Consistency of these agents early is the key. So, any teaching, any evidence to share, Antonio, around multimodals for joint surgery?
I think it's one of those things I would hit the nail on the head is really trying to give multiple different medications and not scaring patients that they take a lot of pills. A few things. One is taking away pain as a vital sign was a big thing. It used to be that that was so important. It's like, are you in any pain? And really understanding that, having some pain after surgery is normal. So expectation management, I think, is something that's been a game changer. I think another thing too is scheduling certain medications, right? So if you don't schedule Tylenol, for example, then patients won't take acetaminophen around the clock. And if they don't take it around the clock, then they're going to be in pain. So, you give a baseline low dose. You tell patients, no, I'm not ignoring you. No, I am actually trying to give you the best possible care by keeping something in your system at all times and then only adding other medications as possible as needed. And really trying to understand that medications are certainly for mild pain, moderate pain, and truly severe pain. And when I scale on a scale of 0 to 10, 10 is like, well, of course it's a 10. I just had surgery. Well, is 10 really the worst pain you've ever had? And they think about it like, no, I had a kidney stone. That was a 10, right? And just kind of doing the expectation management in addition to the multimodal, very similar regimens. We have multiple pills. One thing that I use as well, gabapentin is a medication that has pluses and minuses to it. But I find that nice for our knee patients. We have to be careful on our older patients. But gabapentin is a nice medication that helps with the neuropathic pain, I'd say, that's more prevalent in knee surgery than it is in hip surgery per se. Blocks are things that sometimes people find useful. So not necessarily a oral medication they're taking, but using something in conjunction with their anesthesia colleagues. Some people like to pre-treat patients with radiofrequency ablation or cryoneurolysis, and those things can have post-operative pain control with regards to reduced opioid consumption afterwards. And then I do pericapsular injections. That's what I do regularly for all of my patients. And I just use ropivacaine, epinephrine, clonidine, and ketorolac. And I use an injection around the knee itself. And I use it around the hip, but I mostly superficially. And that's really helpful with regards to some pain control for patients. I do warn them that there can be a rebound effect. So after 3 days, you can have some more increased pain afterwards. But hopefully by that point in time, again, they're taking their acetaminophen around the clock. That's helpful. I give anti-inflammatories as well too, and I want them to take that around the clock as well too. And then as time goes, turn that into a as needed basis.
That's fantastic. Just to kind of build on both of what you guys have shared, so much of it is about, and you both touched on this, is communicating with the patient. That this is a deliberate strategy. It's not like do what you want, take what you want, but you as the doctor, the surgeon, the prescriber have a deliberate pain management strategy that you want you to follow. And sometimes people, I mean, not sometimes, very often people poo-poo Tylenol, but it's really the mainstay of most pain management strategies. And if it's utilized regularly and balanced with other agents, that's remarkably effective. But so much of it is relaying that early, so they kind of get that. So I appreciate both of you guys sharing your perspectives on that. The next question I want to ask you is a little bit on enhanced recovery after surgery. Emma kind of touched on that a little bit, this Eros thought, and I'm sure this will be somewhat familiar to you, but that concept of strategies, including pain management, to optimize surgical outcomes from a pre-op, intra-op, post-op perspective. Do either of you have any experience with that and any Eros protocols or pathways you guys are using? Ahmed,
Yeah, yeah, sure. This is a big passion of mine because I do a lot of outpatient ASC joint replacements, and we have to have those pathways set in place. And even the patients I do at the hospital, they're on those same pathways. I think a lot of it starts with expectation in the office. So when I start describing to patients, if I set a situation, tell me about knee replacements, and I'm like, the surgery is going to be pretty quick, 45 minutes within an hour. You're going to you're going to spend 4 days in the hospital. You're not going to get out of bed, and then you're going to walk, and then you're going to go to rehab. I think mentally it kind of sets the tone that I'm going to be in a lot of pain. I'm not going to be able to do too much, and then I'm just going to have to lay around until I'm better in a couple of weeks. But that same conversation, when I set the tone, and everyone along my team is setting the same expectation, you're going to go home within a couple of hours. You're going to give you all these medicines. You're going to be well equipped to be able to go home. You can do stairs. You won't love doing stairs, but you still have the ability to do stairs. You're going to have these assisted devices. You're going to have good family support, friend support. It kind of marinates in their mind. And then when they come see me a couple weeks before surgery, they already know they're going home. They already know a lot of these things are in place. And then you hit them hard on the day of surgery with a lot of those non-narcotics, IV Tylenol, the PO Celebrex. I maximize on the pregabalin I give patients preoperatively. I'm a big believer in steroid utilization. So everybody gets IV Decadron. And I also add some dexamethasone or Depomedrol into my pericapsular blocks as well. I do a lot of nerve blocks with Exparel. So we're really hitting them hard with non-narcotics. Spinals are all non-narcotics as well. So they're bouncing back pretty quickly. And the idea is the first 3 days after surgery, it's going to be a honeymoon period. So don't take that lightly. While you're in that honeymoon period, take the medicines as prescribed, as Antonia suggested. We give them a nice schedule. 6 a.m. you take this, 10 a.m. you take this, 1 p.m. you take this. And as they're getting ahead of it, once the blocks and everything starts to wear off a little bit, they're pretty comfortable. So we're seeing less and less of them hitting a brick wall in terms of that really bad rebounding effect. We still see it, of course, in certain patients, but some of that is going away. So I think enhanced recovery really starts with expectations in the office and reiterating to them the same process and really encouraging them. And then you pepper in all the medications and the nerve blocks. I think it's been profound so far.
Antonia, do you want to add anything to that for EROS pathways or protocols?
Pretty comprehensive. I think the biggest thing is we took it from our general surgery colleagues. And what we did is really the hydration prior to surgery is a big thing. I have patients who had a previous joint that came in, they're like, but after midnight, I can't eat or drink anything. And you're like, actually, you can now. Um, so I think the biggest thing is we do hydration 3 hours prior to surgery, not 2 hours, because 3 hours, just in case they overstep it a little bit and they end up going a little earlier, we have a little bit of a buffer time. We ask them to hydrate with some sort of electrolyte drink. The hardest part is the first early morning patient. They're like, I got up in the middle of the night to drink. And you're like, is that good or bad? Then you get a good night's sleep and all sorts of things that happen from there. And then they come in, they're like, well, you told me to drink 2 liters. It's a lot of fluid. And you're like, oh goodness. Like, this is one of those things where I don't want you to be dehydrated, but I don't need you to be like going to the bathroom every 5 minutes. So, people come in, they're like, I don't like Gatorade, I don't like Powerade or things like that. And try to make sure they do a low sugar or sugar-free version. Because those things have a lot of sugar in them and that causes its own problematic area. For true ERAS protocol, that's probably the biggest thing that we've done from a hydration perspective. And then prior to the IV fluid shortage, we would give them 1 liter of IV fluid in the post-op or PACU area right after surgery, again, to keep them hydrated, to prevent things like hypotension and keep them, they haven't eaten since midnight. So it's one of those things we want to keep them well nourished. I really like the idea of treating our patients as athletes. Right. And even though our patients tend to be older, the nutritional supplementation, the protein, things like that are all great. I don't currently do that in my practice unless they have low albumin. And then we do supplement them with regards to nutritional supplementation. But I think there are ways that we can really improve what we do. But that's the biggest ERS protocol that we took home.
Just to build on that for those who aren't familiar with EROS, so this broader category, this broader strategy is about optimizing the surgical experience from pain perspective and just an overall recovery perspective. And it's a combination of doing things pre-op, intra-op, and post-op. And the big things pre-op, like both Dr. Chen and Dr. Siddiqi mentioned, is a lot of hydration, up very close to the time of surgery, because oftentimes people are not oftentimes they're always NPO after midnight. So they can be completely dehydrated and empty and depleted for 6, 8, 10, 12, 14 hours. So for those reasons, hydrating, and then even prior to the day of surgery, as Ahmed mentioned, like, improving your nutrition, and then intra-op in terms of your blocks and your medications, optimizing those, and then post-op, use the multimodal regimen. That kind of a deliberate strategy. The data has been really impressive in terms of how people do, and it is a bit of a paradox to what we've been taught historically. Have to have an entirely empty stomach. Now, we're not saying have a hamburger before surgery, but it's about fluid hydration primarily. Can you guys, and you guys have already touched upon this, but can I ask each of you to just summarize your basic post-operative pain management strategy with the pills given? Because many joint surgeons who are listening will be curious, and in general, surgeons are always curious what other surgeons are doing in terms of what you are writing for and how much and for how long for your multimodal pain management strategies. Antonia, do you want to go first, and then Ahmed?
Have Ahmed go first.
All right, Ahmed, go first.
So I do 1,000 milligrams of Tylenol every 6 hours for 4 weeks. I'll do 15 milligrams of meloxicam once a day with food for 4 weeks. I'll do 20 milligrams of Pepcid twice a day for a month as well. I'll do 750 milligrams of Robaxin 2 or 3 times a day for muscle spasms. I'll do 75 milligrams of pregabalin at nighttime. But if anyone's saying that they're feeling really lethargic or they just kind of feel weird, that's the first medication that I stop. If pregabalin is not approved or requires a prior auth, I'll switch to gabapentin. I'm doing more and more of that now, actually, especially because pregabalin is a little bit, I have to sign off on it. My nurse can't just prescribe it. So I might switch to pregabalin a little bit more just out of ease. I give them Zofran as needed for nausea, vomiting. For one day, I give them 4 milligrams of Decadron for a day after surgery to kind of help with the nausea, vomiting, pain as well. And for some low risk patients, I started giving oral tranexamic acid 3 times a day for about a week after surgery. And these are patients that are not on any anticoagulation, no recent stent history, no recent MI, no recent strokes or anything like that. So purely low risk patients to see if that's made a difference. And in my early experience, it's made a tremendous difference, actually.
Just
and then
one.
I give them tramadol and oxycodone as needed, 20 tablets as needed for pain.
Okay, and just one follow-up question because it's always relevant with joint surgery. And what's your anticoagulant, if anything?
I give them baby aspirin twice a day, and that
Okay.
has some analgesia effect as well.
Okay, great, very comprehensive. Antonia, what do you do?
Way less than Ahmed does. So
You have them bite on a
very
belt, and
similar.
that's it.
What's that?
You just have them bite on a belt for
I
a few
mean,
days.
that's all you need. Just, suck it up and just take it like a champ. No, just kidding. So a lot of similarities, as you can imagine. So, start low and go upwards. The one that we do schedule is Tylenol, 1,000 milligrams. I do it 3 times a day. I don't do it every 6 hours. And then that's the baseline. I like meloxicam, 15 milligrams daily. Sometimes patients like to split that up in 7.5 milligrams twice a day. Some of my colleagues use naproxen, 500 milligrams. But I like meloxicam. That's my go-to baseline. For the next step up is tramadol, 50 milligrams, Q6 hours. And then that's like a moderate pain. And then for severe pain, it's either oxycodone, 5 milligrams, Q4 to 6 hours, or Dilaudid, actually 1 or 2 milligrams every Q4 to 6 hours. We don't use hydrocodone. We don't use Percocet just because the Tylenol component to it would be too high. So I like to keep that Tylenol or the acetaminophen around the clock. Gabapentin for my knee patients. I don't do that for my hip patients. 100 milligrams 3 times a day for the first week, and then go to 300 milligrams just at night because that's when patients have a hard time sleeping. So I say it's a really nice thing to give patients at a bigger dose when the pain has started to subside after that first week, but they have a really difficult time sleeping at that point in time. Aspirin, 81 milligrams twice a day for a DVT prophylaxis, typically, and then dexamethasone. We give it, during surgery itself, and then 2 days post-operatively. At 10 milligrams once a day for 2 days after surgery. For my pericarp injection, the ropivacaine, epinephrine, clonidine, and ketorolac, but no added stuff, no dexamethasone, no antibiotics, nothing else is part of it. So that's the pain regimen that I typically use.
What I think is fantastic is how comprehensive both of those protocols are, and you're really covering your bases and really giving your patients the best chance of kind of optimize their outcomes. That's really wonderful. Last question relative to your personal protocols, and you can talk about what you do or what you understand in terms of literature and would recommend. And let's talk specifically around blocks for total knees. So, what strategies do you advocate for, or what's your thoughts on them in general? Emma, do you want to go first?
Sure. So I do. I have my anesthesiologist do an adductor canal and an IPAC block, and then I'll still give a pericapsular injection anteriorly. I don't really go in the posterior aspect of the knee with an IPAC block, and I've had pretty good success with that. I think the data kind of goes everywhere in terms of blocks and what's beneficial and what's not. I do have them use Exparel in the blocks. I do find that to be helpful in a lot of my patients. I don't think it for those that are going to be in pain are always going to be in pain no matter what you give them. But I think for the vast majority, I've had a really, really good experience with that. And my strategy is, it's hard to say which one's better, which one's not. But as long as we're conscious of the costs associated with everything, I try to throw everything in my power at some of these patients to kind of keep them comfortable and to really be able to do good, successful, safe, pain-controlled outpatient surgery. So I do the blocks. I give them pericapsular injection. We really hit them hard with some of the narcotic medications as well.
Thank you. Antonia, blocks?
So it's interesting. One hospital I'll do blocks, and the other hospital I don't do blocks. And so, do I notice a big difference in my patients? I don't know, to be perfectly honest. You're not wrong to do blocks. You definitely need specialized personnel to do so. I know that in some facilities that doesn't delay the case. I know in some places it does delay the case. And so I think that unfortunately plays a big part of things. What I do is I do pericapsular injection. I do in the posterior part of the knee, and I put it around pericapsular as well as some superficial as well too. It does have epinephrine, so I do it in the beginning of the case, so it helps reduce some of the bleeding. So hopefully that reduces some of the swelling. I don't apply a tourniquet for my patients for my total knees. Obviously, there's no tourniquet for hips. But it's one of those things where I don't do blocks for hips. Patients for hips tend to do pretty well. And if you have good anesthesiologists, that's great. When you have a lot of anesthesiologists in training, or who's listening, who's in training, thank you for what you do, but it definitely takes a little bit longer because of that. So I'm not sold in either direction. I will say that I do Operation Walk, and our anesthesiologist did use Exparel in our blocks, and they were actually quite good. So that's something to consider if you're going to do some sort of block. And I think the hardest part that I have a good difficulty working with anesthesiologists is timing of blocks. So I would love to do blocks after surgery when I'm done the surgery, so that gives maximal effect. But I have some anesthesiologists who said that, well, if you're doing intra-articular injection, I can't do it afterwards. I need to do it before. And if I do it before it, I can delay the surgical procedure getting into the operating room. So trade-offs in both directions. Never wrong to do it. I don't think you're necessarily wrong to not do it either.
Yeah, I think that's really well put. And the other point you emphasized, which I totally agree with, is so much of blocks is anesthesiologist dependent, and both how good they are at it, how efficient they are at it, et cetera. And I would agree. I don't think you absolutely have to do it from reading the literature on the topic, but it's in general, though I think a big part of total joint surgery, particularly on an outpatient basis. I think it's utilized regularly. Last question for you guys, kind of wrap this all up. Future directions on research on this topic. Are there areas that you think need further investigation, and or areas that you're investigating that you want to share? Emma, you want to go first?
Yeah, so I don't have any active investigation in terms of opioid utilization, but I'd be curious to see as patients are getting younger, they're getting more active. We're doing a lot of ERAS protocols. We're hitting them hard with a lot of non-narcotic medications to see if any of the prescribing patterns change and utilization changes, more than just beyond the couple of days after surgery, but more along the first 30 days of surgery. Is week 3 different than week 4 after we're giving them all these medications? They're younger. My average patient now, I just last checked, was they're around 59 years old. So they're definitely getting younger and younger, and they're getting really a lot more active. So is age going to have any difference in terms of our prescribing patterns and utilization? I'm not 100% sure, but I think that's where some of my future research may lie.
Thank you. Antonia?
I I love to see innovation in this space with regards to different pain regimens. So, liposomal bupivacaine or bupivacaine slow release or different things like that are great. But I love to see technology such as, embedding bupivacaine in a polyethylene, for example. Or, people have created these patches that have, bupivacaine and meloxicam, and you can stick them in the joint and it's a slow release, slow dissolve, as point someone who can potentially have pain relief for 30 days. I think innovation in this space, the research that goes behind it, both in the basic science perspective, working on different nociceptors and, reducing the amount of pain that people feel, the benefit of gabapentin, it works on a different receptor than what we're typically used to. Are there others that can do it that don't have addiction to it or have less side effects? That's where I would love to see the novelty change. Now, that's something that I don't have expertise in at all whatsoever, but to the drug companies listening, to those who are in R&D, like, I think that's where the future is, to really make it so that, people talk about having a pain-free knee. I would love to have a patients with pain-free knees. Hips are pretty close to that right now, obviously not fully pain-free, but in the knee space, I think we could really do that well.
Thanks, Antonia. That's and Ahmed as well. That's really compelling and um, definitely something to aspire for. I personally am pretty proud of the advances we've made in pain management across all the different surgical specialties. Just over the span of my own career, it's been dramatically different over the past 10, 20 years in terms of what we're doing. And as Dr. Chen said, I think there's still a lot of opportunity to advance this space for better outcomes, more safety, less opioid abuse and addiction, and its related complications. So, with that, we're going to close. I want to thank you both for the discussion and for all your expertise in teaching. In closing, at SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down, it allows the authors to maintain the ownership of their work, and most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world with no requirement to purchase access or pay for a subscription. So thank you for joining us. Till next time.